Welcome all to the weekend classroom of IS Pharmacology Difficult Podcast. I'm your host, Dr. Radhika Vijay, and today we are going to start off with another weekend classroom. We'll be covering the topics from Monday to Saturday. They were all in all 3 episodes, and let us get to revise and get to have the podcast summary for these 3 episodes now. So the purpose of the weekend classroom, in case you are new to the weekend classroom, is to learn, revise, and examine yourself. As you listen to the podcast, you get to know things, new things, and you learn them. Then you can revise them as I jot down the basic important points as bullet points in this particular weekend classroom. And in the same manner, you can examine yourself how much you have derived from the learnings, and by revising and by knowing new things, how much you've got to know. And let us get started. So on Monday, we did the introduction to the elimination kinetics of drugs, and in that I told you first of all about the pre-systemic drug metabolism. The pre-systemic drug metabolism is also known as the first pass metabolism. Now the definition is the metabolism of the drug as it crosses the absorption site to reach the systemic circulation is known as the first pass metabolism or the pre-systemic metabolism. You can surpass this first pass metabolism by changing the route of drug administration. You can give it sublingually, transdermal, intravenous. That is very good because intravenous has 100% bioavailability. Now, as a special note, I added a comment on the hepatic extraction ratio, that is ER liver, and I gave you an equation for that. It is defined as the fraction of the absorbed drug which is protected by the liver to get assimilated into the systemic circulation. It is given as the ratio of the clearance of the liver upon the hepatic blood flow. Then I summarized some important points about the first pass metabolism. Let's get to know them quickly. For the drugs having high first pass metabolism, you need to be cautious. You have to give the oral dose in high amount as compared to the parenteral routes. Patient having a liver pathology will have a high oral bioavailability. Variations in the first pass metabolism lead to the individual variations as far as the oral dose is concerned. Next, if two oral drugs they are competing each other for the first pass metabolism, then the bioavailability of the object drug increases. After the first pass metabolism, I started with the introduction to the drug elimination kinetics. Now, once the drugs they are converted to water-soluble metabolites, our body has a unique phenomena of eliminating the drugs. Elimination is not similar to excretion. Elimination actually includes the two terms metabolism and excretion. The major routes of the elimination of drug they are renal, fecal, alveolar, and biliary. While the minor routes, they are skin, sweat, hair, saliva, etc. After giving the introduction, let's get to know about the biliary excretion. And in that, we will be covering the most important enterohepatic circulation. Liver has unique transport mechanisms for a lot of drugs and endogenous substances. The endogenous substances, they are the bilirubin. And the drugs involved which are transported by the liver, they are colchicine and corticosteroids. Most of the drugs, after being transported from the liver, are excreted into the feces, but there's always an exception. Other part or the other rule may be the drugs, they are secreted into the intestine, then they are reabsorbed back. And this cycle repeats itself and goes on as a vicious circle. This process is known as the enterohepatic circulation. Very good example is digitoxin. It converts to digoxin and then it undergoes the enterohepatic circulation. Other drugs are indomethacin and vitamin D. Some of the drugs, they follow some other route. They are not reabsorbed back after being secreted into the intestine. They are deconjugated. They are hydrolyzed and the enzymes, they work on it and they release the parent drug. This parent drug is reabsorbed back and this enters the enterohepatic circulation. This path is followed by drugs like tetracycline, chloramphenicol, etc. As far as morphine is concerned, gastric lavage should be done for morphine and it should not be allowed to reabsorb back into the enterohepatic circulation because there will be dangerous effects as far as morphine poisoning is concerned. The main purpose of enterohepatic circulation is a sort of conservation as a reserve, and it makes the drug long acting. So these were the important points out of the Monday episode. Let's move on to the next day's episode, that is Wednesday. On Wednesday, we started with the actual routes of drug elimination apart from the biliary route that we covered in the first episode. The first one, the major route that we covered for the drug elimination was fecal route. If the drug fails to get absorbed in the gut, like neomycin, streptomycin, etc., they are excreted in the feces. Some of the drugs, they fail to get reabsorbed into the enterohepatic circulation in the gut. These drugs, they are erythromycin, corticosteroids, etc., and they are also excreted in the feces. The transporters used for the organic acids, they are OATP and MRP2. For the bases, it is OCT, and other transporters are P-glycoprotein and special transporters for the steroids. The next major route that we covered was the pulmonary elimination. It is also known as the alveolar elimination. It is adopted for the gaseous drugs, for the drugs which are highly volatile. The ideal drugs, they are nitrous oxide, general anesthetics, ether, etc. Now, lipid solubility generally plays no role here. It is the partial pressure of the drug in the blood that governs this particular whole thing. The importance of pulmonary elimination is in the medico-legal importance, especially when the drivers, they are gone through the breathalysis in the traffic accident incidents, and they are analyzed for the concentration of the alcohol in their breath. The minor routes covered were the skin, hair, sweat and saliva. Sweat can secrete a lot of urea derivatives. Griseofulvin is secreted by the keratinized epithelium. Hair follicles secrete mercury salts, iodides, arsenic, etc. Saliva secretes drugs like phenytoin. And one important part, that if the drug is excreted in the saliva and you gulp it back, then it is equal to the dose of the drug and it works like an oral dose of the drug. Then let's come to Saturday. That's the last day for today's weekend classroom. And in that we covered another major route of drug elimination, that was the drugs eliminated into the breast milk. They are not important for the sake of the mother. They are more important for the sake of the suckling infant because it gets more affected by these drugs. So let's get to know the whole mechanics. The main important mechanism involved is the passive diffusion. It governs the whole process of the elimination of the drug into the breast milk. So a high lipid solubility and low plasma protein binding, they are favorable for the drugs to get eliminated into the breast milk. The pH of the milk is around 7, slightly acidic. So basic drugs, they are trapped via the process of the ion trapping and they get concentrated into the breast milk. The drugs that are secreted in the breast milk, they are morphine, chloramphenicol, ergotamine, OCPs, diazepam, etc. As far as the status of the acidic drugs is concerned, they may also cause some serious side effects in the newborn. Like sulfonamides may cause jaundice or kernicterus in the newborn. Ampicillin may lead to the diarrhea. Penicillin may cause allergy. Phenobarbital can cause sleepiness. Theophylline can cause restlessness. And if the infant is deficient in G6PD enzyme, then drug hemolysis may occur. Then drug-induced hemolysis may also occur. It is seen with the drugs like quinine, primaquine, nalidixic acid, nitrofurantoin, etc. So the most valuable advice in this particular regard is, as far as the lactating lady is concerned, don't administer any drug to the lactating lady unless and until it is needed and very essential. So that is a piece of advice. Next, I talked about the examples for the different drugs and the breastfeeding and what can be their status and how dangerous and how mild they are. that all you can listen in the podcast episode. They were only examples. Now let's come to the Sunday episode. Yeah, this is a sort of a bonus episode that I did in this particular series. So it's a very short episode, but it has a very important topic, that is drug dosage. Well, in this I will be covering the drug dosage, 5 types, and first is the fixed dose. The desired effect from the drug is obtained at much below the toxic dose. Second is the variable dose. In this also we have 2 types. One is with the crude adjustments and one is with the fine adjustments. So first of all, let us talk about the variable dose with the crude adjustments. In this particular case, the fine adjustments, they are insignificant. The endpoint is difficult to measure, and the endpoint may also vary as according to the various pathophysiological factors. The next is the variable dose with the fine adjustments. In this particular case, the vital functions like the blood pressure, etc., they may change according to the changes in the dose, and they can be repeatedly easily measured. They also provide the endpoint. The adjustments made should be accurate. The next important type of dose was the maximum tolerated dose. In this particular case, the ideal therapeutic effect is not achieved because there are a lot of unwanted effects that occur. What is the usual method adopted? To increase the dose till the unwanted effect appears, and you have to increase the dose before that only, not to reach the unwanted effects. And after reaching that particular point where the unwanted effects just begin, you slightly reduce the dose, and then you have to monitor the plasma concentration. Then the last one is the minimum tolerated dose. It generally applies to the long-term adrenocortical steroid therapy, especially in the cases of inflammation or immunological conditions. That is in case of asthma, rheumatoid arthritis, etc. So with this, we finish off with the weekend classroom. We have discussed all the details that we covered in the 3 days, Monday, Wednesday and Saturday. Hope you derived value out of it. If you really did, please hit the like button. And in case you liked the video and found it of great importance, you can share it, and you can subscribe my channel in case you haven't subscribed yet. And these are the links given where you can listen to my podcast episodes. That is on my website www.ispharmacologydifficult.com. The Twitter and the Facebook page links are also given in case you would like to follow on the social media handle. For all the updates and latest episodes of my podcast, you can visit these links. And stay tuned, stay happy, stay enlightened. Thank you.